The following podcast is part of a certified educational activity titled Chair's Take, Review of the Latest HCC Therapy Advancements. Access the entire activity and complete the post-test at peerview.com/MAJ860. Downloadable slides and practice aids are also available.
Hello and welcome to review of the latest HCC therapy advancements. I'm Dr. Richard Finn from the Geffen School of Medicine at UCLA. During this presentation, I'll be reviewing important and exciting developments happening in the management of patients with hepatocellular carcinoma, including the latest evidence presented at the 2020 ASCO annual meeting, and help interpret what all these data mean to our patients. Liver cancer is an important problem in the United States and globally. While the majority of cases globally are related to hepatitis B and occur in Asia, the incidence of liver cancer is rapidly rising in the United States. Historically, this has been driven by hepatitis C. But as we see treatments for hepatitis C are improving, we still expect a rise in the incidence of liver cancer because of other etiologies, especially non-alcoholic steatohepatitis or fatty liver disease, also known as NASH. So liver cancer is a growing problem. While we've made progress in other malignancies and we see a decrease in death rate, the death rate in primary liver cancer is growing. When we think about patients with advanced liver cancer, we're really referring to patients who, by the Barcelona BCLC staging system for liver cancer, have stage C disease. Keep in mind, to have advanced liver cancer, you do not necessarily have to have tumor outside the liver. Advanced liver cancer by the BCLC staging system are patients who have symptomatic disease from their tumor burden, patients who have multifocal disease in the liver causing these symptoms or invasion into the blood vessels of the liver, as well as patients who might have extrahepatic spread. This is different from patients and the large bulk of patients we often see who have intermediate liver cancer or Barcelona stage B. And these patients are often characterized by having single or multiple tumors in the liver, but they typically do not have symptoms from this disease and do not have vascular invasion or extrahepatic spread. And for this intermediate group, local regional therapies have been the benchmark. But keep in mind, patients are not cured by local regional treatments. Often these treatments improve survival and patients can have several of these in sequence. However, if they do not have a liver transplant or some other curative modality, they will stage migrate and become advanced because eventually they will develop extrahepatic spread or vascular invasion. So for the patients who have advanced liver cancer, the benchmark for treatment has been Sorafenib since around 2008. And from the SHARP study where Sorafenib was compared to placebo, we saw a hazard ratio of 0.69 in patients who are Child-Pugh A with good performance status. Sorafenib has a well-known side effect profile associated with hand-foot skin syndrome, as well as other VEGF type of effects, such as hypertension, as well as diarrhea, anorexia, and weight loss are all things that need to be proactively managed. In 2018, we saw the approval of Lenvatinib, and Lenvatinib was approved based on showing non-inferiority to Sorafenib in this advanced population. In that study, the hazard ratio was 0.92, with a difference in survival of only a few weeks. And by the study design, it was considered non-inferior. Again, it was patients who were Child-Pugh A and good performance status, but importantly, they excluded patients who had invasion of the portal vein outside the liver or extrahepatic portal vein invasion, also known as VP4 invasion. And it also excluded patients who had large tumor burden involving over 50% of their liver or bile duct invasion. Needless to say, Lenvatinib is a very good option for patients like Sorafenib in the frontline setting. Lenvatinib did show that it had a higher response rate as well as a greater delay in progression-free survival than Sorafenib when looking at secondary endpoints. In addition, the side effect profile of Lenvatinib is different than we see with Sorafenib. While there is some overlap, such as fatigue, anorexia, and diarrhea, Lenvatinib does have a higher frequency and intensity of hypertension and proteinuria, whereas Sorafenib has a higher incidence and higher grade of hand-foot skin reaction. Some things to keep in mind when we consider a frontline TKI for our patients. And keep in mind, we're talking about patients who have advanced disease such as Barcelona C, or those patients who are Barcelona B with intermediate disease that has progressed on TACE but not achieved the features of those with BCLC disease. So some of the exciting advancements over the past few months has been the development of a novel combination regimen looking at combining VEGF inhibition with PD-L1 inhibition. The regimen of Atezolizumab and Bevacizumab was proven to improve survival over Sorafenib in the IMbrave 150 study. This was the first phase 3 study that has shown an improvement in overall survival versus the standard of care of Sorafenib. It's interesting when we think about the science behind this because VEGF inhibition has been around for some time in cancer medicine, and historically we've thought of this as a mechanism of depriving tumors of their blood supply and normalizing the vasculature for better drug delivery. But over the years, a lot of excellent science has elucidated the fact that blocking VEGF in malignant vasculature can change the microenvironment and change different subsets of immune effector cells. And this is proven out now in the clinic that we see synergy between VEGF inhibition and PD-1 and PD-L1 inhibition. The IMbrave 150 study was published in the New England Journal of Medicine in May of 2020, and this was an open-label study of Atezolizumab and Bevacizumab versus Sorafenib. This was a global study and open-label, and patients were randomized 2-to-1. Importantly, because of concerns about Bevacizumab's risk of bleeding, patients were required to have an endoscopy within 6 months of going on trial to make sure there were no high-risk varices that could bleed. There were 2 primary endpoints in this study, one of them being progression-free survival, which was improved with the combination with a hazard ratio of 0.59 or a 41% decrease in the risk of progression, and we saw that median PFS went from 4.3 months to 6.8 months. Even more importantly is the other endpoint, which is improvement in overall survival, the most important endpoint in cancer medicine. And what we see here is that the hazard ratio was 0.58. That's a 42% decrease in the risk of death with the combination versus standard of care Sorafenib. Sorafenib had a median survival of 13.2 months, and at the time of this data cut, with a median follow-up of just over 8 months, we still had not reached the median survival in the combination arm. If we look at some benchmarks, we can say that the median OS rate at 12 months for the combination was about 67%. What's very exciting about the new combinations of IO and VEGF strategies, or even IO and IO combinations, which we'll discuss a little later, is that we're seeing very high response rates for our liver cancer population. We've known for a long time that with the drugs we have available in front line and second line, specifically the TKIs or the monoclonal antibody ramucirumab, that we improve survival without inducing a high rate of objective responses. However, as you can see on this slide, the independent review from the IMbrave 150 study showed an overall response rate of 27% with the combination. This is quite significant because it also includes a number of patients who had complete responses, and the duration of these responses were quite long. We still have not reached the median duration with the combination. So the exciting results from the IMbrave 150 study in terms of efficacy need to be balanced against any new safety signals. Reassuringly, the side effect profile from the combination seemed to mimic the side effects that we see from either agent alone. There was no increase in severity or frequency of the known side effect profile, such as hypertension and proteinuria with Bevacizumab. When we look at things that were common between the combination and Sorafenib, such as diarrhea or anorexia, we see that the frequency and severity were higher with Sorafenib. In addition, we have very little incidence of hand-foot skin syndrome with the combination as well. And when we look at patient-reported outcomes from this study, there was a significant delay in deterioration in quality of life with the combination as compared to Sorafenib. recently, the FDA granted approval to Atezolizumab and Bevacizumab. The regimen also has been listed in the NCCN guidelines. And so now we have three options for frontline therapy: Sorafenib, Lenvatinib, or Atezolizumab and Bevacizumab, which showed an improvement in survival versus Sorafenib. At the ASCO meeting this year, we saw some interesting data in the liver cancer space. Abstract 3531 actually looked at the single-arm Atezolizumab and Bevacizumab data set and used a novel technology to look at detecting circulating tumor DNA to assess responses. In this study, though, in a small subset, identified that those patients who have a decrease in their ctDNA from baseline over time with treatment tended to be more likely to have longer PFS as well as disease control, as reflected by responses. So potentially a surrogate that could be incorporated into clinical research in the future. In addition, Abstract 4585 was an interesting study looking at a network meta-analysis presented by Dr. Vogel from Germany that did an analysis to try to compare the combination of Atezolizumab and Bevacizumab to other therapies based on cross-trial comparisons. And while this is not perfect by any means, it was interesting to see that in their analysis that the combination gave very similar improvements in overall survival as compared to Lenvatinib or Nivolumab based on data from the CheckMate 459 study. There was also a poster presented about the patients who had responses from the IMbrave 150 study. This looked at the characteristics of patients who achieved a complete response or partial response in the study. And importantly, there was no one clinical characteristic that identified the patients who achieved a response or complete response with treatment. In fact, the IMbrave 150 study actually had a fair number of patients who had high-risk features such as extrahepatic spread and macrovascular invasion. There were some new molecules presented. There was the phase 2/3 ZGDH3 trial that looked at Danafinib versus Sorafenib. This study was done only in Asia and was a study looking at this novel tyrosine kinase inhibitor and actually showed an improvement in survival of Danafinib versus Sorafenib. One of the first times we've seen a TKI improve survival versus Sorafenib with a hazard ratio of 0.84 and the p-value in the intent to treat population was 0.04. Like Sorafenib, objective responses were quite uncommon with the response rate with Danafinib of 4.6%, whereas with Sorafenib 2.7%. Toxicity was fairly similar between both molecules with all grade 3 AEs, 57% with Danafinib and 67.5% with Sorafenib. We also saw at ASCO an update of the 116 Keynote 524 trial. This is an exciting study evaluating the safety and efficacy of Lenvatinib and Pembrolizumab in combination. You'll remember that Lenvatinib is approved in the frontline setting and Pembrolizumab has accelerated approval in the second-line setting for advanced liver cancer. And this initial study has been reading out over the past several months as the data matures, initially starting as a small phase 1b study, but now expanded to over 100 patients. And that data set is presented at the ASCO meeting with a data cutoff and median follow-up of 10.6 months. The data presented showed that in combination, the overall survival in the frontline setting was 22 months. That is a very provocative number for frontline liver cancer, given it's a single-arm study. We also saw progression-free survival by RECIST criteria of 8.6 months and modified RECIST, which takes into account the enhancing characteristics of liver tumors. PFS using modified RECIST was 9.3 months. If we look at response rates by independent review in this study, we see that by conventional RECIST, response rates are around 36%, and by modified RECIST, 46%. The duration of these responses were quite long, by conventional RECIST over a year. That is quite striking, and this regimen is now being evaluated in the phase 3 LEAP study. There were no new toxicities from this regimen. Again, the toxicities that we've seen with Lenvatinib and Pembrolizumab individually were seen in this study. The most common grade 3 treatment-related adverse event was hypertension. And it should be noted that the FDA granted this regimen a breakthrough designation in July of 2019. So while the LEAP-002 study has completed accrual and we are waiting for events, also we should comment that the phase 3 COSMIC 312 trial is ongoing. And this trial is looking at the combination of Cabozantinib, which is a multikinase inhibitor to VEGF, c-Met, and AXL, which is approved in the second-line setting, in combination with Atezolizumab, with a control arm of Sorafenib. This study is ongoing and builds on this scientific rationale of combining VEGF and multikinase inhibitors with PD-1, PD-L1 inhibition. The other exciting area in liver cancer research is combination of checkpoint inhibitors. At ASCO this year, my colleague Katie Kelly at UC San Francisco presented data from a large phase 2 study looking at Tremelimumab, the CTLA-4 antibody, with Durvalumab, a PD-L1 antibody. These patients were generally patients who were naive to immune checkpoint inhibitors and had progressed on Sorafenib or were intolerant or refused Sorafenib. So it was a little bit of a mixed population and included patients who would be considered frontline. And they tested several different regimens here, a single dose of high-dose Tremelimumab with Durvalumab versus a lower dose of Tremelimumab dosed 4 times and then continuing Durvalumab versus single-agent Durvalumab and single-agent Tremelimumab. So a 4-arm study with the primary endpoint being safety and then looking at other things such as response rate and biomarkers. If we look at survival in this study, we see that with high-dose Tremelimumab and Durvalumab, median OS in that group was 18.7 months. That was longer than the other arms of the study, where single-agent Durvalumab gave a survival of 13.5 months, single-agent Tremelimumab 15 months, and then the lower dose Tremi and Durvalumab combination of 11.3 months. Interestingly, grade 3-4 treatment-related adverse events were fairly low in this study, with 35% in the combination and no grade 5 treatment-related adverse events in that arm, and an overall response rate of 23% with a median duration that had not been reached. These toxicity and efficacy data support the further development of this high-dose arm in advanced liver cancer. And along those lines, this regimen received an orphan drug designation in January 2020. The phase 3 HIMALAYA trial, which was a 4-arm study of Durvalumab versus 2 different dosing regimens of Durvalumab and Tremelimumab versus Sorafenib, has completed accrual and results are awaited, with the primary endpoint being overall survival. The other dual checkpoint inhibition phase 3 study that's ongoing is the CheckMate 9DW study, and this is a randomized study of Nivolumab and Ipilimumab versus first-line TKI, Sorafenib, or Lenvatinib, with a primary endpoint of overall survival. This regimen is already approved in the second-line setting based on accelerated mechanisms from the CheckMate 040 study, and we'll talk about those data soon. So in summary, I think we're entering a new age of liver cancer treatment. We still have the backbone of treatment being tyrosine kinase inhibitors, but I think those will be moved mostly to the second-line setting, as we have seen the recent approval of Atezolizumab and Bevacizumab. That regimen has a very high response rate and, importantly, a good safety profile and an improvement in overall survival. And as that rolls out into practice, I think physicians will have to learn how to select patients best to receive any one of these available treatments. And still, very exciting are the upcoming data sets from immunotherapy combinations, which are showing us that they can have very high response rates and durability, and we eagerly await the results of the phase 3 studies. We'll now turn our attention to the second-line landscape, where we have several approved options and have seen some recent data from ASCO, which we'll discuss. There are currently 3 agents that have been approved in the second-line liver cancer space based on phase 3 data. There are some other drugs that are approved based on accelerated approval, mostly the immuno-oncology agents, But if we look at Regorafenib, Cabozantinib, and Ramucirumab, they were all evaluated in similar phase 3 designs versus placebo, with some caveats. For example, Ramucirumab required a baseline AFP of over 400 for enrollment, whereas the Regorafenib study required patients to have confirmed radiographic progression on prior Sorafenib, and they had to tolerate Sorafenib for a minimal period of time before coming on study. Whereas the Cabozantinib study actually included patients who were allowed to have 2 prior therapies. So there was actually a subset of patients who were considered third line. Needless to say, when we look at the magnitude of benefit, all these studies are fairly similar. Hazard ratios for overall survival of 0.63 with Regorafenib, 0.76 in the intent to treat population with Cabozantinib, and 0.69 with the Ramucirumab dataset. Both Regorafenib and Cabozantinib have similar side effect profiles consistent with the other VEGF multi-targeted TKIs. And Ramucirumab, as a monoclonal antibody to VEGF, was generally very well tolerated, with most side effects linked to its. So the adverse event profile of Regorafenib and Cabozantinib are very similar to what we see with other multikinase inhibitors that target the VEGF receptor and other proteins. And Ramucirumab, as a VEGF receptor targeted monoclonal antibody, most of the side effects there can be linked to its mechanism of action and is generally well tolerated. Rego and Cabo are both given orally, Rego with a 3-week on, 1-week off regimen, Cabo continuously, and Ramucirumab is intravenous every 2 weeks. At ASCO, we saw results from Asia looking at a new VEGF kinase inhibitor, Apatinib, versus placebo in the second-line setting. This study included patients who mostly had first-line chemotherapy prior to coming on study, and this study was specifically done in China. And patients were randomized 2-to-1 and showed that median overall survival with Apatinib was 8.7 months, with placebo 6.8 months, with a hazard ratio of 0.78, with a p-value less than 0.05. PFS was more than doubled from 1.9 months to 4.5 months. And again, response rates were slightly higher with Apatinib at 11%, though again, not as high as we've seen with some of the newer IO regimens. There were more treatment-related adverse events with Apatinib, but at the end of the day, I don't know how this study will impact those of us in the Western world, as it was done only in Chinese patients. However, proof of concept that this molecule is active in second-line liver cancer. In second-line liver cancer, there are several immunotherapy molecules approved. Both Nivolumab and Pembrolizumab have had approvals in the second-line setting based on accelerated approval, and these are generally approved based on durable responses in the 15 to 20% range. So Nivolumab and Ipilimumab have received FDA approval in March of this year for second-line treatment of advanced liver cancer, and this was based on an expansion arm of the CheckMate 040 study looking at 3 different dosing regimens of Nivolumab and Ipilimumab. Arm A, which is the one that has moved forward into a phase 3 study in the frontline setting and received FDA approval, consisted of 50 patients, and we saw a response rate of 32% and a median duration of response of over 17 months that translated into a survival in second line of just under 23 months or 22.8 months. This is a very large number given its single arm and a small number of patients, but it's very exciting to see how this will perform in the phase 3. It's important to note that adding Ipilimumab to Nivolumab increases side effects, and in fact about 50% of patients in Arm A required steroids to manage treatment-emergent autoimmune events. So now there are several options available for patients with advanced liver cancer in the frontline and second-line setting. This is a very exciting time for our patients because we have a lot of options for them. And this improvement in our care has really occurred only in the last 2 or 3 years. Now, we had Sorafenib since 2008, but all these new approvals are very exciting, and it's important for us to try to figure out how best to incorporate this into our treatment paradigms. In the frontline setting, we have Sorafenib, Lenvatinib, and now Atezolizumab and Bevacizumab. And then in the second-line setting, we have Regorafenib, Cabozantinib, Ramucirumab, or for patients who don't get IO in the frontline setting, Nivolumab, single agent, Pembrolizumab, single agent, or the combination of Nivolumab and Ipilimumab. It's important to keep in mind the data that was generated in the second-line setting was really generated for patients who had only prior Sorafenib, given the other two treatment regimens of Len or Atezo and Bev only came around in the past few years. Needless to say, I think in practice we'll have to extrapolate the data we have in order to figure out how best to treat our patients moving forward. Now, in closing, I'd just like to highlight some of the strategies to try to move these drugs that we have in the advanced setting into earlier lines of therapy. Again, when we talk about earlier lines of therapy, we're talking about patients with intermediate stage liver cancer or Barcelona B. These are patients who typically get local regional therapy alone, and then, should they progress, will then be candidates for systemic treatment. So the question is there a way that we could delay progression to advanced stage or even cure some of these patients with intermediate disease by incorporating some of these novel drugs into earlier lines of treatment? There are several studies that have looked at incorporating systemic treatments into TACE. Most of these were done with Sorafenib after its approval, but there were two other studies with other VEGF receptor kinase inhibitors that have not been approved otherwise, including Brivinib or Rantinib. And these studies generally did not show a significant improvement in survival or other endpoints when using TKIs as single agents in combination with local regional therapy. Last year at ASCO GI, we saw the results of the TACTICS trial, which did show an improvement in progression-free survival with TACE and Sorafenib versus TACE alone. However, that study used some novel endpoints and has still not had a true overall survival readout at this time. And I don't think at this time most of us would recommend using systemic treatment in combination with local regional treatment outside of a clinical trial. At ASCO 2020, we saw some results of a small randomized study looking at Lenvatinib as an adjuvant to TACE in patients who had high-risk features for early relapse after chemoembolization. There was a trend towards an improvement combining Lenvatinib with TACE with median recurrence-free survival of 12 months with the combination versus 8 months with TACE alone. That's a hazard ratio of 0.5 and a relatively small study, but does provide some rationale for evaluating some of the newer drugs. There's been some interesting science done by the NCI group that has looked at combining liver-directed local regional therapy with immunotherapy with the idea that using destructive treatments to tumors can release neoantigens, and then using immunotherapy you can activate a T-cell response against these antigens and against the tumors. And they've actually seen some evidence of an abscopal effect, meaning that tumors outside the treatment area done with local regional therapy actually have some response. So there are a number of ongoing phase 3 trials of immunotherapy in various stages of liver cancer, a number of studies that we're awaiting results on in the first-line setting. We have approvals in the second-line setting. These drugs are being moved into the intermediate stage in combination or in sequence with local regional treatments such as TACE. And exciting studies are now being done with either single agents or combinations of therapies in the adjuvant setting, meaning after patients have a curative resection or curative radiofrequency ablation but are considered high risk for relapse. And all of these results will be very exciting to see because they can actually change our practice for the better for our patients with liver cancer. So in closing, it's very exciting to keep in mind that we now have many active options for our patients with advanced liver cancer. In order to optimize our treatment, it's important that patients be triaged appropriately to the right treatment at the right time, and to keep in mind that patients who are receiving local regional treatment most likely will progress beyond the efficacy that can be achieved with that approach. So when patients are developing new tumors or extrahepatic disease or vascular invasion after receiving chemoembolization or radioembolization with Y90, it's important to step back and think, is this patient an appropriate patient for systemic treatment? We want to maximize the benefit from these drugs, which means we need to have patients whose liver function is not decompensated. Once a patient starts to have decompensated liver disease, then it will be harder to improve their survival by treating their cancer. And this means that we need multidisciplinary care. All physicians who are involved in the care of patients with liver cancer have to work together. It's important that we educate our patients as well as our community physicians about looking for liver cancer. This is a very common disease, and unless you look for chronic liver disease, you won't find patients who have curable liver cancer. And there's a number of patient resources available. Patient advocacy organizations such as Blue Fairy and others have a lot of available resources, and I urge you to take a look at their website at www.bluefairy.org.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MAJ860. This educational activity is supported by independent medical education grants through AstraZeneca, Bristol Myers Squibb, Eisai Incorporated, Exelixis Incorporated, Genentech, and Merck & Company Incorporated.